Yeah, for those who just joined, if you want to turn your camera on or not, that's fine. Again, I was given just a little nudge of instruction from Michael Pasciarlo when he asked me to moderate the session, mostly that this was an informal, much like a special interest group, for us to kind of casually share what we're all doing in the context. And for this one, it's around aging. So I will give it maybe to 1:45 Eastern time, and that's 3 more minutes to see if anybody else populate. This is day 2 of the conference, so I don't know if this is when you start seeing the people jumping overboard to return to their non-Zoom activities.
That has to be the hardest part is staying focused and not being, yeah, I'm gonna have to watch the, I watched part of the talk from this morning.
Yep.
I hope others were able to join. It was very interesting what I was able to watch though.
Oh, great. Oh.
Where are people from?
Yeah. What? So again, the value of this session really is in just kind of information sharing around our work around health literacy and aging. So I mean, I'm happy to introduce myself first and then do a go around to those of you who want to share and participate. But my name is Mike Wolf. I'm a professor in general internal medicine and geriatrics at Northwestern University's Feinberg School of Medicine. I direct, since 2019, I direct the Center for Applied Health Research on Aging at Northwestern. So fall of 2019 was a funny time to launch an institution endowed research center and expect to get it off its feet pretty well. And then in 2020, we received a Claude D. Pepper Older Americans Independence Center, which are called Pepper Centers. It's a longstanding National Institute of Aging network that is focused on improving clinical management of older adults. And so that's my skin in the game on aging research. And I'm happy to talk more about what I'm doing, but I'd rather learn more about who else is on the call. So Jen, you've got your camera on. Why don't you introduce yourself?
Hi, my name is Jen Gann. I'm from the University of Arkansas for Medical Sciences, and I work in the Center for Health Literacy and the Department of Medical Humanities and Bioethics. In the past, my background is actually clinical research in neuropsychiatrics, so Alzheimer's disease, schizophrenia, depression, anxiety. So that was my previous research. And then now at the Center for Health Literacy, we do have one project. I'm working with our CTSA site, which is the Collaborative Translational Research Center. And we're looking at just being very aware of the NIH wanting to have inclusion of older adults across lifespan and involved in research to increase representation. So we're kind of looking at it from both the provider side as well as the patient side. I think right now we're planning on a provider-facing video on tips for including older adults, not in necessarily like Alzheimer's or cancer studies, but more in like general chronic diseases, just to bring awareness. So that's a little bit of what we're doing right now.
Great. Anyone else would like to? Sue, I haven't seen you in a long time. How are you, Sue? I think you're on mute, but if you want to say hi and introduce yourself.
Hello, it's great to see you too. We haven't seen each other in a long time.
Are you still up in Maine?
I'm still up in Maine, yeah, but I'm doing some work with a couple of the medical centers in the northern New England area. So I'm also I'm also the health literacy consultant for a federal program, the Geriatric Workforce Enhancement Program.
GWEP, yeah.
The GWEP. So I'm the health literacy communication consultant for them, and we've been doing some work around health literacy with providers who are serving older adults to a large extent. So we're trying to engage the providers and the office staff and creating some materials to facilitate that process for them.
Great. Well, it's good to see you.
Thank you. You
We're
too.
all like digging out of our holes, our COVID holes. Is it Radhika? I hope I pronounced your name correctly, but you want to say hello?
Yeah, you did fine.
Oh.
I'm Radhika Devraj. I am at Southern Illinois University, Edwards Law School of Pharmacy. So I teach a component of health literacy to pharmacy students, along with the a larger class on cultural competency. My interest in health literacy has been there for a couple of years now, and I have attended this conference before. I used to do a lot of health literacy work in kidney disease, and then have done a little bit of pharmacist understanding of health literacy in, overall. But more so, my interest in coming to this session is because I'm embarking in looking at Parkinson's disease, and wanted to kind of get to know if anybody had any interest in that area, what types of health literacy work has been done there, if at all. I haven't seen any much, but thought this would be a good session to attend.
Yeah, it's great. Well, awesome. Hey, Jerry, how are you?
Hey, Mike, how are you? It's been a while.
Yeah. Want to say your your name, ID badge, everything?
Sure. Jerry Baumblett, working in a few areas. I was interested to come to this both because, well, my husband actually works on hearing aids. So obviously there's a lot going on there. And then I also work co-founder of the Difference Collaborative, which is working to help family caregivers, a lot of which is, helping seniors. And then also working with a social good organization called DACALA as their chief engagement officer, which is basically a free patient education communication platform, and constantly always getting like, well, we could use this, but can seniors use technology and that sort of thing?
Yeah,
so,
exactly. Yeah,
yeah.
We have a core that's in our Pepper Center. That is, the goal is we have a design institute that came about through some money from Crate and Barrel of all places at Northwestern, and through our aging center that we launched in 2020 with NIA. One of our cores for the national network is on user-centered design for older adults specifically. So they're working right now as our first product is an evidence-based manual of best practices for designing technologies for older adults.
Oh,
and we have
that's great.
We have two junior faculty scholars funded by our center that are both working on off-the-shelf technologies that can be readily implemented to support older adults' mental health and well-being by alleviating caregiver burden. So,
oh, really?
Yeah. So actually, it's a really cool. They just put in a project, so that's a whole other thing to talk about.
Oh, yeah. We should definitely talk more.
I want to see Tom's got his camera on. I want to say hi to Tom, and so you want to introduce yourself and what you're working on?
Hi there. Yes, I'm a professor at Texas Women's University, the School of Health Promotion and Kinesiology. My first career was as an airline pilot, and I flew internationally for years. When I retired, I went back and got my doctorate and taught at TWU, the Denton campus, north of Dallas-Fort Worth, for about the last 16 years. And one of the courses I'm teaching in the spring is the health aspects of aging. So I thought I would find out what's going on, and this is a great place to steal wonderful ideas put in the course.
So I got to ask, with your background, what is your take on all this air rage?
I think it's just the world that we live in, and people have been cooped up for a very long time. And I think there's, unfortunately, we have politicized a public health issue.
Mm-hmm. Yep, absolutely. I don't know if anybody else, it's fine to just kind of be a fly on the wall for a networking session like this, but anybody who, feel free to turn your camera on, or just or even just speak up if anybody else wants to introduce themselves, camera on or off, it doesn't make a difference. Everybody's welcome, but I see we've got a few other people that joined it, but if anybody else wants to speak up and say hello, here's your chance. In the meantime, we do have some questions floating about, like Parkinson's, getting back to Radhika's request. But before we do that, Chelsea, hi.
Hi.
Nice to meet you. Didn't know if you wanted to introduce yourself and if you have anything going on in the aging health literacy space.
I don't not necessarily in the aging space, but I work in community engagement at Kaiser Family Foundation. A lot of groups on this in this conference have cited KFF, so that's always nice to see. We are a large organization, so the team that I sit on, we focus on designing campaigns, and so that was what I presented earlier. And our campaign is called The Conversation, La Conversación. I can put a link to it in the chat.
Great.
So I've been here, So I've been here since the start yesterday. A few notes that I've taken. Again, it's not related necessarily to aging, but I'm a little concerned at the kind of maybe overlooking, I think, of factors such as like race, ethnicity in some of these presentations. I will be really honest. Now, that being said, the presentation that we're sharing is very much focused on trusted messengers in these communities. And so I think that's really a crux of what health literacy can be. If it's not necessarily designed by messengers that look like the community, then that might be a major factor to something not being able to be received. And so I just want to share that out, because it can also affect when we're trying to reach our aging population. One of the examples I did see when we were just starting to get COVID related data was that older Black adults were being missed from like something related to catching COVID related data, because older Black adults do not live as long as other racial and ethnic groups. And so that's like one of those examples where if we're not thinking about how race and ethnicity is correlated with something like age, then we might miss some of that data. And then if we're trying to get health literacy related information to that population, to older Black adults, if we're not factoring in race, then we're missing people. And so I just say that because I think that we have a great opportunity here. I think COVID has really highlighted a lot of these unfortunate disparities, but us as a health literacy community, we also can think more about critically and how we can really include that information in the work that we do. Thank you.
Yeah, I think that's I appreciate all of that. I think that you're exactly right. I think in thinking on the past 20 months and counting, it's just been an absolute, I cannot think of a worse case example of how health literacy has not been put into practice, how we have not been able to get ahead of the misinformation, how we are kind of constantly chasing after, this kind of public health disaster. And from, being in Chicago, where at the very beginning, I think, the former president basically kind of ostracized our city, calling out, basically on our disparities that we were noting, and it's still never, in the Black and Hispanic communities, in particular in Chicago, they've been incredibly hardest hit. And I think in terms of the messaging and the tailoring of the strategies and trying to understand like what the barriers are, the distrust in the system, I think all of that kind of has been in this very erratic pattern. So I mean, I don't know if anybody's got a great case example of what's been done well in terms of kind of culturally tailored, literacy appropriate, language appropriate, rational, organized, accessible information and communication around I think on anything around healthcare during this time has been just really messed up. So
I don't know if you can remember back. Some of you are not old enough to remember the HIV/AIDS epidemic that we lived through in the 80s. And I did a content analysis of several major newspapers and news magazines by circulation, and looking at headlines. And I noticed that the HIV and AIDS was in the news all the way up until 1996, when the first protease inhibitors came about. The death rates started to go down, went out of the news. And one of the things that it speaks to is that public health and public health messaging has a short time and a very important time to get the facts out about any epidemic or pandemic. And it's essential that they control the messaging, public health in particular, and even using basic health literacy principles.
yeah, well, no, thank you. I mean, now, Sue, you've been doing the good work of health literacy for the long time. I'm curious what your perspectives are on, because you've been on the ground in health systems, addressing a lot of this for years. I don't know, did this feel just unusual to you?
We have another population with huge disparities that I have not heard mentioned is that I'm in Maine. We're probably the whitest state in the country, which is nothing to brag about, but it's the way things are. And we have a white rural population in the whole northern half of the state that is incredibly politically conservative, has refused to get vaccinated. Church pastors and other noted community leaders are speaking against the vaccines, which is really difficult. So with the WEP project I'm involved with, we're trying to provide physicians that work in the area with information that's clear, simple, health literate, easy to read, reasonably attractive, and to just have available to counter the misinformation that's being propagated by other groups. So it's really incredible. Some of the work I've done within large healthcare delivery systems is that they're so pressed, the marketing teams in the hospitals are so pressed so fast to get stuff out, and the hospital regulations keep changing all the time. They just don't have the bandwidth to really deal with this effectively. That's what I've seen. They just have to keep cranking stuff out. I mean, the rules keep changing about hospital visitation policies, and whether vendors can come into the hospitals, and whether surgeries are going to be permitted first or not. First, elective surgeries are not going to happen, and then they are, and then they aren't, and then they are. And so even beyond the broad public health messages that we want to get out, the systems that I'm working with are just struggling incredibly. I don't know if that's what the information you were looking for,
Well,
Mike.
yeah, that's the perspective you're seeing. I know that's great. I think, in thinking of, herd immunity and what we need to be capturing, if you're not getting everybody, and what it's becoming very stark as to exactly who's not making movement. And that's exactly what you described in terms of the demographics in Maine, as well as what you're seeing out west in the South. It's sad, but yeah. Well, just other thoughts on not just on COVID, but in terms, or even on what's happening right now, but just in general. I'm curious if anybody else, this is an aging panel. It can be whatever you want it to be for this session, for that matter. But whether it's COVID, where obviously 90+% of everybody who's died of COVID has basically been over 65. Has with multi-morbidity, most likely. It's definitely really been driven home by an older adult population. But for us, a lot of what we're interested in too is, the indirect effects of of COVID-19 right now, and the indirect benefits possibly too, where you've got a lot of patients, older patients who have just an innate need for healthcare because of their comorbidities. How has their access changed? Are they going to get lost in the system? What is the effects of mental health has been a big issue. The indirect effects on caregivers, and their access to their families at this time. The other things we're interested in a lot right now is, is there kind of a slight glimmer of hope that some of the benefits of telehealth might actually continue, even though the reimbursement's kind of falling aside, now that we actually showed that, yes, you may think that old people can't use technology, but guess what, they're quite savvy at a lot of these technologies, and they actually like it in some regards. There's a lot that also is to be improved upon, but Marina Serper, my colleague yesterday, gave an example at how Penn is doing it probably pretty successfully. So anyway, just throwing out some stuff. If anything sticks.
one of the things that I've noticed in the press are reports that, and I haven't read any research articles, that because of COVID, people being fearful of going to the doctors have put off, particularly older adults who are more susceptible, have put off things that they need to have been doing, and therefore they are seeing disease progression at a later state.
Mm-hmm.
And that's really problematic.
Yeah, absolutely. And I mean, like, I remember at the beginning of the pandemic when you got into May and June, and our colleagues in the emergency medicine department were like going, where are all the heart attacks? Where are all the strokes? They're just, they're not seeing them anymore. That something is afoot, but and I think, we're still doing a data mine of our own large healthcare system data, and Kaiser, I'm assuming, could do it tenfold better, but like just how many patients have kind of gone dark, that there are all of a sudden there's just no biomarker data, and yet this is someone with type 2 diabetes and hypertension, and you don't have a blood pressure reading or an A1C on them, for 18 months. I mean, my colleague again at Penn, a patient, a liver recipient, right before the pandemic, literally did not come back in for any of their follow-up, mandated checks, and showed up in the emergency room. Somehow or another, their immune suppression held enough, but they were like literally, 2 years having kind of just vanished and coming back now out with major health issues. So yeah, I think we're going to be digging out of this for quite a while. But yeah.
And I will speak to that. So I'm Taryn Overturf. I'm in Indiana, and I'm actually a health promotion consultant. So I use my CHES a lot, and I work for the Medicare Advantage population. So again, and noticing that like right now we're doing a bunch of breast cancer screening awareness because of how many women just didn't complete their mammograms last year with, again, with the electives not happening. And I want to say, to an effect I'm seeing when I talk to these women, a lot of them are saying like, oh, my doctor didn't mention it. And I think it kind of goes back to that fatigue on the provider standpoint. They're already inundated trying to play catch up with a whole extra year worth of patients they haven't seen. So yeah, trying to come up with more a dialogue to have, and also education, because I work a lot with the kind of northwest part of Indiana. So Gary, I don't know if anyone's kind of familiar, but that's like the worst, city in America. Very poor literacy, poor education, poor in general. The median income is so much more below the median than the United States. It's astronomically crazy, but that's kind of where I'm at, a standpoint of what else can we do, and utilizing technology has been great, with the telehealth, but again, because of the population, a lot of them are still using kind of the Obama phones, and you get so many minutes per month, and they're gone within like 3 to 4 days because they're calling doctors trying to get in, or calling for cabs. So I think this is a big problem, at least on my end, that we're facing is how do we engage, the providers to say, hey, you need to take this extra 5-10 minutes to discuss these screenings. Yes, it may not be on your mind or not what they're coming in for, but when we're saying, hey, you need a son, oh, my doctor didn't say anything. Well, you haven't had a mammogram in 4, 5, 10 years. So,
I know. That's a great point, and you're seeing that too. This, this is going to be a rough challenge. I mean, it's interesting when I think about it. Our whole system, technically did not shut down. It closed down quite dramatically, as many places did in like the last week of March 2020. But we reopened by May 15th, and a lot of it was because I think the financial impact of that 6 weeks or so off was considerable, and telehealth persisted through December until it started to kind of became very clear through reimbursement and through just also health systems saying, no, we really need to see you in person at this point, and so they just shifted it. But it really was brief, but it still has kind of this lasting effect of people maybe still not ready to come back. A lot of what we're trying to figure out is how do you phenotype those older adults in particular who are kind of going under the radar, that may be having mental health issues, who are still kind of, a bit shell shocked by COVID and not wanting to, see their physicians in person, or they're not rebounding to it. So that's going to be tricky in the coming months. So.
Yeah. I'm also, I mean, we're still seeing the problem too, like you were saying about not even identifying who the family caregiver is.
Mm-hmm.
So, I mean, my mom has been in and out of the hospital, not with COVID, but for other reasons. And because of COVID, I couldn't go to
Mm-hmm.
see her or be there. And in terms of, they almost gave her a drug that probably would have potentially killed her had I not happened to be on the phone when the doctors were rounding. And it's really difficult in terms of like this balance of helping both the developing resources that are friendly to seniors, and for seniors to understand, and then to also make sure the caregivers have, I mean, even when the caregivers were in the hospital, they weren't getting the training and the identification that they needed to often do the right things. But now, especially that they're not even there physically, I think it's even harder to make sure that the hospitals or the care teams are finding out who is the caregiver and how can they support this senior. So that's definitely been one of the challenges. Even when my mom gets hearing aids, there's no education, and so she'll like give up on them. And it's like, oh, didn't they tell you that your brain has to get used to the hearing aids and this type of thing? And so I still see there's like just zero education and training, even in technology that we know are mostly going to seniors.
My father-in-law also, he had an acute event, and and recovered at the beginning of right before COVID, but then during COVID, his adult children did the same thing, is in terms of talking to get the hearing aids in, and adherence is horrible, especially in the front-loaded front end. Like just getting acclimated to it. It's hugely challenging and obviously impactful on health literacy and just social engagement if you don't get that right. So, and if you're not, I think caregiving, like another, again, trying to find those little silver threads of hope that you kind of figure out maybe our system will be learning and in a meaningful way. I don't know, but one, again, the notion of caregivers having access, the notion that you can't be in the exam room during a lot of the COVID restrictions, and so they needed to come up with ways to kind of maybe more formally grant proxy access through patient portals, to start really recognizing maybe we do need to document, if there's actually, like, formally document in a queryable way that there's a caregiver involved. But to that end of it, I think the other thing we started to learn on is, one, patients were finally starting to have to migrate to a portal if they hadn't been using it before. We were seeing an uptake in our own health system. And two, health systems were starting to recognize that if we really need to use these technologies to manage our patients, we better figure out how to make them user friendly. And I feel like that's been some feedback. And again, with Marina's present yesterday, I think like they realized really quickly what's not working, and they had to do that in real time. So again, I'm trying to be half glass full here, even though I recognize that it's only just kind of chipping away at the many complexities of our healthcare system. So going back to Radhika, does anybody can anybody help identify anybody doing good work in Parkinson's? I'm trying to round that back to you.
That would be really helpful.
Yeah, sadly, I don't know right off the bat. I'm not aware of. I think it's in some ways it's a great thing because it means that you're a pioneer, but in some ways it means that you like sometimes being a pioneer, you like to have someone along for the ride.
Right.
So we have great Parkinson's clinicians and researchers on over here, but in terms of people doing like health services research, especially in health literacy and that topic, less familiar. Now, Jerry, you've got a pretty advanced, your worldview has been pretty expansive on clinical pieces and health information.
Yeah, I think I missed, I think I was just coming on when you were introducing yourself, so I missed what you're doing in Parkinson's or trying to do in Parkinson's. There is a Parkinson's organization that I did a health literacy, like participatory medicine talk for a couple years ago. I can look up who they were. They were international. Honestly, in a strange way, some of the only things I've seen in terms of raising understanding about different things that happen with Parkinson's have been in pharma, trying to like help people understand, oh, there can be these other symptoms with Parkinson's, like hallucinations that people aren't familiar with. And then I've seen some, no, that was Alzheimer's. I'm trying to think. I feel like a lot of it, so much of the research has been around Alzheimer's.
Yeah,
I think we do need more around Parkinson's though.
Yeah, there's a ton of work in Alzheimer's and dementias, but yeah, I haven't seen anything in, and there's just recently the Michael J. Fox Foundation had a database they have a database that's publicly available that's sort of skewed more towards mostly white, non-Hispanic participants from the US. Although it's a worldwide database, it's mostly populated with people in the US. And even in that, even in that database, there's been some analysis looking at communication and finding that there's poor communication about some of symptoms of Parkinson's. And I'm surprised that there's not much work done, therefore. So I'm kind of excited in a way.
One person I should probably connect you with is my friend Lynn Becker. She's potentially partnering with that foundation. She actually works in traumatic brain injury, which potentially causes or can contribute to Parkinson's. And she has created an app that helps like track different TBI symptoms, but I think it would probably has a lot of crossover with Parkinson's. Anyway, there might be some tools she's developed that could be helpful, because I think that's a lot of the problem. Even when I was working just in dementia, generally helping create an assessment, is that when I would test it with families, they were shocked at that some of the things in terms of the way people would even fall or different things like that were potentially related to these different neurological issues. And so that seemed like a huge health literacy issue, just in terms of trying to help people. Like, it's not just memory issues, or with Parkinson's, it's not just, shaking or issues like that, that there's much more expansive things that you can identify earlier on in terms of like symptoms. So I feel like what she's doing might be really helpful for you, but I can connect you with her.
Oh, that would be wonderful. I can, she can give me email or something on the
chat.
I'll
send it to you right now.
What's her name?
Her name is Lynn Becker. She's, what is it called? It's like Powered by Patients or something like that. But she's actually created an app that helps people track different traumatic brain injury symptoms, because her own daughter had like traumatic brain injury and it wasn't diagnosed and treated well for a long time. And she's a researcher, so she knew how to do this. So she ended up designing this. But I think in terms of the neurological conditions generally, people are they think it's only memory issues, or they think it's only like gait and shaking, and they don't know about all these other things that might be related. So I think it's really interesting, but I'll send you my email right now.
Yeah, great. Thank you.
So
Yeah, I think,
just before I forget, Jory Flesher, who used to be at NYU, who's now in Chicago at Rush, I'm assuming she's neurology. She's based in there. She's an MD. She's written a study called Low Health Literacy and Underrecognized Optical and Parkinson's Disease, and she's done a couple other studies on associations with outcomes in medication beliefs in Parkinson's.
okay.
I was surprised that I didn't know she was here. But yeah, anyway, just another connection as well.
Thank you.
I'm trying to find her contact information, but I'll put it in the chat if I can find it. Oh, Sue, yeah.
One thing I'd like to just talk about a little bit here is something that I've observed over and over and over again, and that is that care providers and caregivers and the general public altogether rarely understand that health literacy is really limited as people age. And again, it may be intertwined with cognitive declines of some kind. Michael, you've done some of the seminal research here. I don't know if you're still teasing that out, or it is what it is. But people are unaware of this. And when I do a lot of introductory health literacy plain language sessions for areas of different hospitals, and they're always shocked that their dominant patient population, which is often older adults who have more medical conditions of both acute and chronic, have that the health literacy skills decline with age. And it's just always a surprise to them, and it's really unrecognized. So I just want to put that out as an awareness piece for all of us. So have you taken your research further, Michael?
Yeah, we have our cohort work called LitCog, where we had older adults recruited in 2007,
right.
Still active, and at least we have funding through 2026 to keep the cohort going. So we're already seeing, I mean, honestly, the one interesting thing is, it's tough to actually measure it, because with lots of cognitive aging studies, retention is lower among those as they start to develop cognitive impairments. But we are seeing a lot of associations where people who had lower health literacy at a younger age are more likely to be on a more steeper trajectory of cognitive decline. We just launched a new cohort like 2 months ago with a new R01 NIH grant, where we're looking at health literacy and cognitive function starting in midlife, recognizing the decisions and actions in healthcare engagement that you have in middle age is a likely, we're looking at kind of modifiable factors, including what we would think health literacy and health activation might be during middle age, that might actually kind of put you on a better trajectory for cognitive function in later life. So we're trying to kind of mirror it. So we'll have this life course of ages 35 to 95 to be able to track kind of health literacy patterns and try to understand what phenotype of person is really going to be, most at risk. But yeah, I mean, a lot of those fluid abilities that are really attached to active learning deteriorate really in the early 70s. You start to see kind of a little bit of a dip. That's when it starts to drive, but it's pretty robust up until that point. But then it starts to go down fairly quickly among some individuals that have, underlying health conditions, especially if they're vascular, and watching them be able to do everything like dose out multi-drug regimens, which most of them have, remember appointments, make informed decisions off of written or multimedia materials, recalling instructions from doctors, so all those little things that really kind of map to best practices. Yes, you need to give people tangible reminders and help them, recall and organize their thinking and their self-management responsibilities. So I think that gets ever precious. We have another cohort that was added to LitCog where we identified caregivers to our active cohort. And that's like on a rolling admission, right? Because people are healthy until they're not. And then when they're not, all of a sudden you have this caregiver who gets thrust into it, not really given a manual of operations for the role. And the theory we had was, to what extent can a caregiver's involvement basically become proxy for health literacy for people with low health literacy? So maybe you don't suffer worse chronic disease outcomes because you're low health literate, but it's okay because you have a caregiver involved. But that only matters if your caregiver is health literate and engaged and experienced, and so a lot of the caregiver is now getting the LitCog battery. Their cognition is getting assessed, their health literacy is getting assessed, because it's really kind of the point being that you need to train people and impart health literacy skills to people who probably never needed to have it necessarily because they were younger and healthier, but now all of a sudden they have to care for somebody else. And so that line of work is really for me to give a shout out to Rachel O'Connor in our group. Is that's her major research agenda. Her interest, not to keep talking on this, but I think it's really cool. She has a career development award focused on older adults with multiple chronic conditions who have a mild cognitive impairment or early stage dementia, and their caregivers, how they co-share responsibilities around medication management and polypharmacy, right? So who's, the goal from the Alzheimer's Association is like, help maintain independence as long as possible. But how do those skills transition to the caregiver? And where are there kind of failures? Because maybe it's not such a formalized process, in terms of the day, like all of a sudden now I have to go fill the prescriptions from my parents, or no, I'm actually filling the pill box. Now I'm actually nudging them when they have to take medicine, to the point where you're basically, I open up and say, I think there's this kind of transition, but it's not just for medications, it's for a lot of self-management skills. So, it's anyway.
Yeah, it's interesting because the caregivers definitely, well, first of all, they're not being identified, and they don't necessarily self-identify. They're not being given the training. They're becoming second order patients because they start neglecting their own health to do this kind of work. But then especially with something like dementia, there are those stats that say that now the caregivers at serious, much higher risk for dementia. Did you see the film? Oh, now I can't think of it. Dick Johnson is Dead?
No.
Oh, so that's really interesting. But it's this woman whose mother had dementia, and her dad was the caregiver, and then her dad develops dementia. And one of my friends said, that's got to be really uncommon. I'm like, no, that's incredibly common. It's something like they're 6 times more likely to develop dementia if you're caring for somebody with dementia.
It's in like kind of stress inflammation pathways.
Yeah, I don't think they've necessarily identified exactly why it happens, but it seems like you're probably becoming socially isolated. The main person you're living with and talking to can't necessarily like converse with you anymore. So for whatever reason, you start deteriorating.
Mm-hmm.
So then her dad got dementia, so she made a documentary film about it. But yeah, so it's a interesting problem, because I think what we see are these caregivers are becoming second order patients. And so the lack of health literacy is affecting both the patient they're caring for and the caregiver's health. They can't care for the patient well if they don't know what they're doing, but that stress and all the difficulty of that and the neglect of their own health starts impacting their health as well.
And the support networks are so important.
Yeah,
they are, but people start to ghost you as caregiving becomes more intense. People are less and less comfortable coming by and helping and interacting with the person who's deteriorating. So
yeah. To that end, what are we? Yeah, I think granted, my confidence in whatever is going to get passed in this congressional budget is going to have a lot of cuts, and many of that may fall on the caregiver support that was an opportunity. I think we're all just kind of going, at this point, how do we get past this? But it's challenging. All around is challenging. We've covered this. This almost has become a caregiving and health literacy panel. Not surprising at all.
I know that about 15 years ago, American Red Cross noted that between 15 and 20 million people live at home and are cared for by another family member. And they wrote a complete program, both written materials and videos, CDs. And one of the subject areas was caring for the caregiver. And while health literacy was not mentioned explicitly, if you looked at the material and the way it was written and the grade levels that it was written and the terminology that was used, health literacy principles were very evident in the production of those materials. And I noticed because I volunteered and taught for the Red Cross for many, many years. And in 2006, there was a major change in the ECC conference about how we do first aid and CPR. And all of a sudden, the American Red Cross's manuals for their community classes and worksite classes for first aid and CPR went from a large manual to just a little pamphlet. And they put everything on the video because they recognized that people didn't read. And that was about the same time the NALS data finally came out from the 2003. It was published in 2006. And I think someone wisely said, wow, we got a problem with reading. Why are we making these big manuals? We need to put this material on video and use very simple terms. So someone at the national office, I've had several conversations, was very attuned to health literacy issues.
Nice. Very nice. So I'm being mindful of time because I know one of the things that people have been complaining about, at least yesterday when I was involved, is the fact that HARC has not really budgeted for time between sessions. So I was going to make sure that we spend we cut out maybe in about 5 to 7 minutes to allow for people to move on to the next session that they're going to. And this has been a nice networking connection. But any other final thoughts? To me, like a nice summary is, there probably does need to be a nice, call to action on health literacy and caregiving. It's a strong point. Going back to, I think just in general, back to, to the aging adult, addressing, another kind of thought piece could be on, how do you optimally design health information for a diverse yet aging society? And that could be specific to not just that would be in print, but also online, and basically across the multimedia piece, and kind of cultivating what is the evidence-based practices that we've learned from a lot of work with older adults. Oh, 1 minute remaining. Okay. I guess we got the hook early, but Sue, you got to spend your long career.
For any of you interested in caregiving for an Alzheimer's patient, the National Institute on Aging has a wonderful piece. It's quite long. It's probably not for not a poorly educated population, but it's really excellent. And you can use just parts of it, not the whole thing. So check that out on the NIA website. They also have a new version of their booklet, Talking with Your Doctor. Again, not totally simple, but they have used principles of plain language. They've used big print, nice font, blah, blah, blah. And it's a lovely little guide. You can pull pieces out of it if you're working with an older population and looking for guidance like this. So
yeah, great.
I'll just mention those as available references.
Yep. All right.
Great to see everyone.
Take care.
I guess we're cut off.
And Radhika, there's actually a lot of money for health literacy in the context of Alzheimer's right now with NIA. So that's the last thing I'll say. They're driving the content. They just to fit it into that box.
All right. Thank you. Nice to see you all.
Good to see you.
Mm-hmm.